Know Your Myeloma Immunotherapy, Teclistamab, and other bispecifics. So when I first did this webinar, I specifically put Teclistamab because there weren't any other FDA-approved bispecifics. Since then, we've gotten Talquetamab that was officially FDA approved, and then FDA fast-tracked was elranatamab. So we have two more bispecifics in the myeloma arsenal. There's articles about both of those on the website that I'll share with you guys as part of our resources because I want you to learn more about them. But that's kind of what we're going to be discussing today. And then I know whenever we talk about bispecifics, the conversation also includes CAR-T, simply because there's so many questions about how do we sequence those and how are they related and how are they different. So don't be surprised if CAR-T is a part of the session today. And if you do have questions on how bispecifics and CAR-T relate to each other, you're welcome to include those in the question and answers as well. It is now my pleasure to introduce Dr. Cartier. She's an assistant professor in the Department of Internal Medicine at UT Southwestern Medical Center. She specializes in stem cell transplantation, immunotherapy, so good thing we have her today, CAR T cell therapy, and treating patients with multiple myeloma and other plasma cell disorders, including amyloidosis and Waldenstrom's macroglobulinemia. She is also involved in clinical trials to develop novel therapeutics for multiple myeloma. Dr. Kaur earned her medical degree at Drexel University College of Medicine. She completed a residency in internal medicine at Tufts Medical Center and received an advanced training in hematology and oncology through a fellowship at Montefiore Medical Center. Am I saying that right? Certified by the American Board of Internal Medicine and Medical Oncology and Hematology, she joined the UT Southwestern faculty in 2020. Her clinical and research interests include improving outcomes for patients with hematologic malignancies, particularly multiple myeloma, by developing newer cellular and immunotherapies, and she publishes and delivers presentations on her work regularly. She is a member of the American Society of Hematology, the American Society of Clinical Oncology, and the International Myeloma Society, among other professional organizations. I'm so happy to have you here, and thank you for taking time out of your busy schedule to be here. I really appreciate it.
Thank you for having me.
Yeah, so I think we'll get started. I already see some questions coming in, which is really exciting. I think we'll just start with the basics and then kind of open it up as we discussed to the patient's questions and caregivers. There might be caregivers here as well. So I want to start with Teclistamab since that was the one that we kind of promoted, but I also want to touch on Talquetamab and elranatamab as part of this discussion. So when it comes to let's just start with the general bispecific antibody. What's your general definition when you're talking to a patient who's considering a bispecific antibody or who you're considering a bispecific antibody as their treatment?
So I think before I even answer that question, I do want to reflect upon the remarkable accomplishments by the myeloma community and our patients, because they're a significant part of this journey, right? In getting therapies approved, that we have 2 immune therapies approved in 1 week. And in fact, if you count Carvykti, ide-cel, Teclistamab, elranatamab, and Talquetamab, that's 5 therapies for a disease that's relatively rare in comparison to other malignancies, right? So I think that goes to the investment of our pharmaceutical partners as well as our patients and the academic organizations and the many people that are within it, right, to make this happen. So that's a remarkable accomplishment. And with that, I like to reflect upon the last 20 years and how sort of we are very fortunate in the myeloma world to have all these therapies available. And we've had so many of them approved in the past 20 years, right? And just in 2 years alone, 5. That's quite remarkable. So as a myeloma provider, I have a lot of hope in my mind when I speak with my patients about what's coming our way, what's happening currently. When a patient comes to me for a relapse refractory consultation and they're interested in immune therapies, We approach both, we address both CAR T cell therapy. I think you cannot go into explaining bispecifics without explaining what a CAR T cell therapy. So they're both immune therapies. They harness the power of your immune system in essentially killing tumor cells. I say, whereas what happens with CAR T cell is that we take your T cells, engineer them in a lab, and make them recognize a cancer cell. In this case, something on the cancer cell called BCMA. It's expressed in myeloma cells. And so that CAR T cell now has a power after it's engineered to go back into your body and to go and say, hey, that's a myeloma cell, let's attack it. And it does the killing itself. So, but that's a time-intensive process, and we can, of course, go into that. Whereas the bispecific is sort of readily available. What it does is it says, I'm not going to do the killing myself, but what I'm going to do is I'm going to bring the cancer cell, because I recognize the cancer cell. So the bispecific, in this case, Teclistamab, elrantamab, and there's a bispecific with AbbVie as well as Regeneron. All of them that target BCMA have the ability to recognize the myeloma cell via BCMA. And then it brings the cancer cell as well as the immune cell, the T cell, together in proximity to each other. And then lets the T cell do the killing. So both harness the power of the immune system, whereas one is off the shelf, readily available. I just have to, my patient needs it, I order it. I have to go through the usual process of getting it approved by pharmacy, by insurance companies, and I'm able to deliver it to the patient, relatively quickly. Whereas in CAR T cell, we recognize that there's a need for this therapy, and then there's several steps involved in delivering the therapy to the patient. First is collection of the T cells. Then the second process is it goes into a lab with whichever company, whether it's BMS or Janssen, because their products are the ones that are approved. And the manufacturing time can take anywhere from 4 weeks to 10 weeks, depending on how easy or hard it is to manufacture the new T cells. And then they get infused back into the patient. So one requires patience, the other one sort of does not. I hope I've answered your question.
No, that was an amazing explanation. Very understandable. Thank you. CAR T and bispecifics, as you mentioned, they're harnessing the immune system in order to work. What are the side effects that patients could expect because their immune system is being, I'll say, manipulated, but in a really great way?
Yes. I think, so yes, we do manipulate the immune system. And as a result of manipulation, you can go into an overdrive, right? The immune system can be overactive. And so some of the side effects that you see with both CAR T as well as bispecifics is something called cytokine release syndrome. What happens is, and there are certain risk factors that increase the risk of having it, or if you have it, the degree of having it. So what happens in cytokine release syndrome is that because your body's immune system now got a signal, oop, there's a threat, I gotta attack it. You produce chemicals, or they're called cytokines, that are a result of this. And it can go from as just simply having a fever to fevers that are not, going down just with Tylenol, to low blood pressure, to increase oxygen requirement because there's an inflammatory process going on that's uncontrolled, to having low blood pressure so low that you can require an ICU stay, and medications to boost up that blood pressure if it's not addressed. So in that, how I described it is basically grade 1, just simply having a fever, to grade 3. And this is how doctors whenever we have a patient with this therapy, we objectively review what are the patient's signs and symptoms that are telling us where they fall along this spectrum of cytokine release syndrome, and our subsequent responses are delegated or are depend on the degree of cytokine release syndrome. If it's just grade 1, maybe a fever, we give Tylenol. If it's grade 1, grade 2 now, and the fevers are recurrent and there's a little bit of low blood pressure, or it goes further than that, then we do, there's a drug that it's called Teclistamab. We give that to put a brake on the system and say, okay, slow down. So there's ways to mitigate it, but cytokine release syndrome is one. And what we have seen with the two types of therapies is that CRS tends to be more of the advanced grades tend to be more with Cartier than with bispecifics, but it is a concern nonetheless, which is why with at least the Teclistamab as well as Elrantamab and Teclistamab, both of these therapies require a hospitalization. So Elrantamab, both of them require hospitalization, Cartier as well as the bispecifics. There's something called a ramp-up phase, which means you give tiny doses of the drug in a short amount of time, every 2 to 3 days, and all of these have schedules, which has been published online with the FDA's guidance and all that, that allow the doctor to give, and the doctor's not the only one, we must remember that, the team to give the therapy and monitor you in a controlled setting for the syndrome of, it's called cytokine release syndrome. Other side effects that can be experienced, oftentimes when we talk about side effects, we talk about early side effects versus delayed side effects, right? The second one is called ICANS. It's basically neurotoxicity that occurs as a result of an overactive immune system, where the immune systems can leak into the brain, and sort of it can be as simple as just being confused or having a headache or difficulty writing or difficulty talking. And again, when we talk about neurotoxicity, that's also assessed objectively and graded by the team that takes care of you in the hospital. And the nurses in the hospital do what's called the ICE assessments. They ask you bizarre set of questions every 4 to 6 hours, depending on the protocol at each institution, to ensure that the patient's with it. And if they suspect that there's a drop in the ICE score, then there's drugs that we have that we can mitigate the neurotoxicity so it doesn't get advanced, because this too can lead patients to the ICU, where they need to be closely monitored. Oftentimes it's treated with dexamethasone. And sometimes when somebody has the CRS as well as the ICANS, doctors and their teams can give both at the same time. That's a judgment call, and every institution has their own protocols, or what we call the SOPs, on how we mitigate them. So these are the two big things that we are worried about when somebody first gets these therapies. And with CAR-T, and with actually to a lesser degree with even bispecifics, with CAR-T, you get something called lymphodepleting chemotherapy right before you get the CAR-T, because you have to make room for the T cells that are going to be infused into you. So people often get low blood counts that usually get better on its own. However, they may transiently get better and then get worse again, and people may need blood transfusions. They may need platelet transfusions. They need something called GCSF support to boost their white blood cells so they're not at risk for infections. So low blood counts is a common issue that we deal with in the clinic, and it requires close monitoring by the patient's team, actually. This is also seen with the bispecifics as well, and the approach is actually very much similar. You see this, as soon as the doctor, your team thinks that you're not at a risk of having recurrent CRS, we are more liberal in terms of ordering and giving the GCSF support. So, you are very, very tightly watched or closely watched, and usually after you get this therapy in the clinic.
Thank you. A couple questions. Again, excellently explained. You certainly have a talent to explain things very clearly. The first is, you talked about there are things that lead to greater risks of these. So from my understanding, the higher your disease burden is when you go into CAR-T, the higher risk that you have of having these kind of reactions. A, is that true? Is my understanding correct? And then B, do we see the same things in bispecifics?
Yes, I think the first disease where CAR T cell was done actually is in lymphoma, right? So the myeloma community have had the fortune of learning from them. We know time and time again that the higher the disease burden, the more chances that you will get CRS, and the higher the chances that the CRS will be a little bit more advanced. So yes, that is absolutely true.
And are we seeing the same things with bispecifics as well?
Yes, disease burden does indicate, although if you look at the trials and the data, you realize that the degree of CRS that you see with bispecifics is not as high as what you see in CAR-T. So, but the statement, I think, can be applied to both therapies.
Awesome, thank you. So just to clarify, with the bispecifics, they will need to be in the hospital for 1 to 2, maybe even 3 doses, and then the continuing weekly doses would be outside of the hospital.
Yes. So usually, I believe Teclistamab per the FDA package insert requires a 9-day stay. I believe I'm actually just looking up because Elrantamab just got approved yesterday, I believe, right? Yesterday or the day before?
Yeah, the day before.
Mm-hmm. The day before. See, I'm in the hospital on
You're
service
fine.
right now, so I got my days mixed up.
You're like, what day is today?
Yes, exactly. And I was just reviewing the package insert for that as well, and that's also given on day 1 for day 8. Those are the step-up dosing, and that requires the hospitalization initially. And then, but with Elrantamab, I believe after week 24, the treatment can go to every 2 weeks, which is slightly different from Teclistamab. And talking to my colleagues throughout the country, we're all sort of, I don't want to use the word expert, but yes, we do this for a living and see this day in and day out. We've sort of developed our own processes within our institutions and safeguards. So, at our institution, we do a 7-day hospitalization. So we've cut it down from 9, and with close monitoring. So if I have conversations throughout the country with different colleagues of mine, they all have somewhat of a different process on how they've adopted these practices, because nobody wants to be in the hospital that long. They want to get out, get their therapy, so it is an inconvenience, but it is because we're in the early days of the bispecifics as well. We have to do this way to build up data that this can be safely done. And I think this will change in the future. I don't, in my opinion, in the future, I think bispecifics will move completely to the outpatient, but the data needs to be there, so we can safely do it, because ultimate thing is safety for the patient.
Yeah, definitely. And I love that example of how real world data and real world clinic experience can influence things that were like originally set because of clinical trial procedures. So thank you for sharing that. 2 more questions, and then we'll turn it over to the audience. One of them is if we can just briefly talk about talquetamab and how it differentiates from elrantamab and teclistamab.
So before I go into talquetamab, I think we must recognize that whenever there's a new therapy, the basis of that therapy is what is different. Let's identify a target. Is there a door? Is there a key or a lock, that is different in another way, in accessing that cancer cell so we can go and kill it. That's really the mentality when the drugs are developed, right? It just depends on how you utilize it, essentially. So whereas Teclistamab, Olrantumab, and Carvykti and ide-cel target what's called BCMA, Talquetamab targets what's called GPRC5D. It's also a receptor. It's also something that's expressed on the myeloma cells. And the beauty of that is, beauty in finding drug targets is you figure out what is uniquely expressed on the cancer cell, because you only want to target the cancer cell. You don't want to target something that doesn't express it, right? So with Talquetamab, majority it's expressed on the cancer cells, but there is some thought process that, you know, with your nair, there's some side effects that we're seeing with Talquetamab, with basically dysgeusia and hair and nail changes, that there could be expression there. But most of it is manageable. So the Talquetamab differs. It's also a bispecific. It brings the cancer cell and the T cell together to target, but it targets something called GPRC5D, and the side effect profile is slightly different. The CRS and the ICANS, that risk is there with all of the immune therapies, bispecifics and CAR T cell in general. But with BCMA targeted agents, we see, especially bispecifics, we see infection being the common driving factor, what we have to worry about. And that's not the case with Talquetamab. The infection risk isn't there so much, and that may have to just to do with the target, because BCMA is expressed on other plasma cells. So patients can get what's called hypogammaglobulinemic, which means your natural antibodies, your usual antibodies that go and attack the cancer, that help you fight infections, they also get depleted. So patients get put on monthly IVIG treatments. This is also, CAR T patients also get it. We've seen a number of infections that are not so problematic if you have an intact immune system, like CMV, you know, they get reactivated. So that needs to get monitored closely. You know, a lot of the data that we have with the bispecifics was that these trials were done during the COVID-19. I mean, COVID-19 is still ongoing, but the early time when we didn't really know a whole lot about the virus, and the medical community wasn't really prepared to deal with it, there were several deaths on the trial, but that was mostly due to COVID-19. And now that we have, you know, antivirals and other things developing, so hopefully that's not so much of a concern. But we're hyper vigilant when we give these therapies to our patients, and we recommend certain prophylaxis against antivirals, and IVIG to support them while they're getting the therapy. You know, Talquetamab is going to get, hopefully, we're trying to get it soon at our institution. And I think aside from the early side effects of low blood counts and CRS and ICANS, we're going to be monitoring if patients are having weight loss, if they're having hair and skin rashes and things like that. So there's going to be the supportive care for patients getting Talquetamab will definitely change.
Yes, thank you. Excellently explained. I'm going to say that after every question because you're so good at it. Okay, I did say one more question, but I'll save that till the end, actually, since it's more of an emotionally based question. And I'll turn to the audience because they have great questions that are going to guide this discussion. One of the ones that I see that I'd like to tackle first, when are these bispecifics approved? People are asking in terms of lines of therapy. And then the other question is, why? Why is it approved so late in the game when it comes to myeloma?
Because you can only go based off the evidence that you have, right? And it's ethical is the biggest thing, actually, because ethics drive the ethos of what we do. I like to believe that, you know, majority of the time, if the drug is studied only in late line, then that's where it gets approved, essentially. And you cannot get an approval for a drug in first line or second line or third line where it has not been studied. And, you know, we are very fortunate. We have really, really good drugs where we have learned how to minimize the side effects and have really, really good efficacy with, the IMiDs, the PIs, and such as lenalidomide, pomalidomide, bortezomib, and carfilzomib, and daratumumab. Those drugs are very good. So
Yeah.
these drugs, the ones that are getting CAR-T and all, they need to do better. They need to do better and have lower side effects if they are going to get approved in earlier lines of therapy. And as regulatory agencies, and probably if you ask all of our the physicians who do this, we also want to see that data before we start recommending this too early on. Now, there is emergent data because both ide-cel and Carvykti had CARTITUDE-4 and Karma, I believe it's Karma-3. Mm-hmm. That data where they studied CAR-T in earlier lines of therapy, and there is a thought process that when you do it early on, the immune therapy is more functional because it hasn't had years of therapy on, that you are going to get better responses, and that is certainly the case. So I know that there are ongoing studies, but that evidence has to be solid before those therapies get approved in that setting. So right now, 4 lines of therapy is where is approved. Now, I wish the language gets changed because it shouldn't be 4 lines of therapy. If I give somebody RVD, or let's say even KRD, because some patients I don't give Velcade up front because they have a pre-existing neuropathy or they have diabetes and other conditions. Your therapy choices are driven not just by what's approved in a paper or a drug, but by the patient. So, and then I give DRD or KRD, they do transplant, and then by the second time they get KPD or Kyprolis, Daradex. They've used up, some of the most effective drugs. So it should actually be, in my opinion, the approvals should sort of come about. What are the patients refractory to? Yeah. And I think then often, I've had this clinical dilemma. I know my patients need CAR-T, but I cannot get either. The trials have their own requirements because there are other trials going on right now. But I cannot get that drug approved by the insurance company because they need 4 lines of therapy. So I have to do something that I know may not be effective just so I do it so I can get the approval. And that's the part where I think it's not okay. And I think many myeloma physicians feel this way, that we need to change this lingo. We need to change this language. It should be more about the drugs that you're refractory to or you've had before, not necessarily lines of therapy.
Completely agree. Yeah. Not that I have a say or anything, but
yes,
I completely agree with what you're saying. Thank you. I was going to ask one more question about that. Yeah. This was another question that I saw frequently asked. So beautifully explained on why it's approved when it is. Do you personally see, and you did mention there are clinical trials happening trying to bring it towards the frontline therapy. Do you ever see it as a first line therapy of induction, or maybe a second line after your very first relapse? Do you see that happening?
Yes, I do. I think there's going to be a group of people who actually need these, because there's one group of patients who I think CAR-T is going to get moved up, but we have to be very mindful that financial burden on as a society has to be taken into account, right? These drugs are very expensive, and that not that shit can't be the dividing factor. So the CAR-Ts particularly, because they're $400,000 or $500,000, and we have to talk about it because this is important. They have to do really, really well to get approved in the early lines of therapy. I think there's a group of patients that have historically not done well with whatever we have done. We've done combinations of 4 drugs, 3 drugs, 5 drugs, and that's the high-risk myeloma group. And I think there were already trials going on that did, if patients got autologous stem cell transplant, they are doing consolidation with the CAR-T, or if instead of an auto transplant, patients got CAR-T. Those types of strategies are being developed, and they are in clinical trials or getting into actual. They've been designed already or going to move forward. where patients actually get enrolled onto this. So I think all of that is fair game and it will happen. It's just a matter of which population are we gonna give this to. And as of right now, our biggest hurdle up until the bispecifics came along was that we had waiting periods, waiting lists for patients to get CAR T because they needed it. But the companies only had so much bandwidth in terms of doing the manufacturing. And that's been a big issue. Some of them are not even at every center that wants them actually. So patients have to travel. So I think we have to address access at this stage. And luckily with the bispecifics being approved, one of the things that we struggled with was which patient gets CAR T. If you have two patients, and that's not a decision I'm always comfortable with. But if somebody has very explosive disease and the disease, there's a high burden of disease, and I think versus someone who has, slowly advancing disease, someone whose disease can wait 4 to 6 weeks can actually wait for the CAR T. But there are patients who need, something immediately, and then the bispecifics comes there. So that has actually alleviated that issue. But there's a lot of these logistic challenges that we have to work through to move the therapies up.
Yeah, very good point. Sometimes it's not just about, the clinical trials, it's about actually introducing it in the real world and thinking about those challenges. So thank you for the insight.
You must realize that when stem cell transplant, which is, tried and tested and, and autologous stem cell transplant, we have within this country disparities in terms of patients accessing that. And this is a therapy that's how many years old? So I can continually see that this will be an ongoing issue as well in terms of CAR T access.
Yeah, definitely. In addition to that, because of the bispecifics and their efficacy and their ability to be off the shelf, do you see that helping kind of overcome this gap of disparities where some people are not able to access the best of the treatment, having this really great treatment off the shelf? Do you see that aiding the problem?
Yes, I do. I think that's exactly the role probably the bispecifics will play, because to do CAR T, it's I think I saw one question that popped up, but it was about stem cell transplant, or if you're not a candidate for stem cell transplant, can you get CAR T? So CAR T patients also go through a similar evaluation as somebody who's getting a stem cell transplant. They get an echo, they get lung function testing done, they get, cardiac evaluation, et cetera, all that. But they also need a caregiver. They need someone to be able to drive and live away from their home if the center is too far away, and all that. So not every person is going to be a candidate for CAR T because it's a risk. It carries risk, and you have to have certain measures in place to be able to deliver it safely. So I think it is going to balance it out. And there are patients who are like, doc, I don't want to get admitted for, if bispecifics make it to the outpatient setting completely, like as in no inpatient stay, and we figure out how to mitigate the side effects of CRS and all that early on, I think I do see that bridging it. But then there's another burden when you go on to bispecifics. Are you going to go on it weekly? And is that something, because patients get tired, myeloma patients, at least the ones, not at least, but like my patients are like, doc, I'm tired. I'm getting these therapies on and off my entire life. I just want to not be attached to you. And I'm like, that's very fair, as much as, so I think they both have their advantages, and disadvantages. And I think with proper education and discussion, the right therapy can be selected for the patient.
Yeah, definitely. Some other questions here. What about age limitations or optimal age for these bispecific therapies?
I think I think it's performance status more so than anything that actually will tolerate. But it has to be what is patient's performance status and how functional is the patient. That determines, and oftentimes, on how we can be aggressive in terms of treatment. I think the frail patients will likely be more towards a bispecific versus a CAR T. I would say I'm a fairly aggressive doc, so I, don't usually factor into account age as much. And it's an honest discussion. If somebody's really, really elderly, like, 90 plus or late 80s and 90s plus, yes, then we'll have a legit conversation. And if, I have 80-year-olds that look like 60-year-olds. So I think I'm very mindful of that. But I think that's the extremes I think about. I don't know if that's a very difficult question to answer, because each patient itself is unique and has if they have comorbidities and things like that. I think yes, maybe for Cartier, age, maybe the upper extremes of age might not be something that they would be considered for, not for so much for bispecifics, I believe, if they have good performance status.
Yeah, very well said. Thank you. People are wondering, how long is the treatment? Does it go until progression? Is there any maintenance therapy? What is the current standard?
So that's a very good question. And I think this is where the real world is going to deviate from the clinical trials. I think, the trials are always done till progression. And I think real world is going to show us, if infection is a limiting factor, then many docs are going to be, we are already very aware of it, actually. So I think you're going to have some neat trials that are going to be happening in studying the duration of therapy, because I think until progression, it depends on what risk they carry. I think that's not going to be feasible. It might be that there's a fixed duration, or that there is a certain response. You achieve an MRD negative response, or you achieve a CR multiple times, and then at different time points, and you can stop. So I think right now it's until progression, but how it plays into the real world is going to be dictated by risk of infections, complications, and there's probably and there's going to be strategies that are going to look into this.
Thank you. I agree with you. And I know all patients hope to see that change from continuous therapy to maybe something else. There were a couple questions when it came to like the ICANS and the CRS. I almost forgot that word. Are those just temporary, or are they something that could last throughout the rest of your life?
So CRS is usually temporary, and mostly ICANS as well. But there are some neurocognitive challenges that can be with certain products, certain Cartier therapies. And I think, so that needs to be monitored for. Some of them actually develop later on and not early on, so it's kind of hard to know. And that's something to watch out with, particularly Carvykti, but it's extremely effective. So usually they are very self-limiting, and if you intervene with the right therapies when the patient is experiencing them, they're reversible. We have patients who go into ICU and are not making sense, and they come out and after a few days, and they're back to their baseline. So it is often reversible.
That's encouraging. A couple of questions here as well about, do we have any data on how long these remissions or responses is probably a more correct word in myeloma are occurring when it comes to these bispecifics, or is it just too early to tell at this point?
Actually, that data is coming out. The overall response rates with Teclistamab was about 63%, I believe, and there was, I'm trying to remember the actual time. What was the duration of response? And I'm actually forgetting the number at the top of my head. But these responses are actually both with talquetamab and with even elrantamab. The duration of response is actually longer lasting. You have to understand, these are patients who are the ones who got therapy in these trials. There are, relapse and refractory patients. The overall survival, not many times when therapies before bispecifics or CAR-Ts were introduced, we were happy with a response rate of 30% or all that. And now we are having consistently with most of these therapies, response rates that are double that, 60%, 70%, 80%, and MRD negative rates. These were not seen before. So I would say that of course these therapies are going to be further developed and enhanced to minimize side effects and to figure out better dosing schemas, or sometimes even combination of therapies, right? They might combine with the DARA, which is the trials are already going on actually right now. Tech and Talc may be combined. So I think those are still in clinical trials and to be seen, but the responses are very much long lasting.
Yeah, it's encouraging for sure, as you were saying. A couple of questions here. I do have one patient, he's on a Teclistamab trial and experiencing kind of the things that you were talking about where it comes to taste is different, swallowing is difficult. Is that because GPRC5D could be found on those organs?
Yes.
Thank you for the clarification. Let's talk about, there was a good question here of, are all bispecifics injections, or does one need a port for them to be administered?
Very rarely should a myeloma patient need a port. A lot of our drugs are now injections, and a lot of them are, or they're IV where they don't need actually a port. I do have this. Teclistamab is an injection, and I believe I have not given elrantamab, and I believe that is as well. So now everybody's moving towards patient-friendly injections and delivery. But I don't think you should ever need a port for these therapies. You should not, unless some patients just generally, after living with this disease for so many years and getting stuck all the time for labs and all that, they get tired. Yes, I am, my personal preference is I only reserve ports for patients who have very difficult access, because we deal with infections, and so I like to minimize them. But that's my own personal practice. Every doc and everyone should have a conversation with their doctor about this issue, right? But of course, access is also important, and constantly being stuck and poked takes a toll.
Yeah. What do we know? We talked about those early onset side effects. What do we know about late side effects, or things that appear maybe even after they're out of the hospital when it comes to bispecific side effects?
So I think we have talked about it at different time points. So infections that can happen once you're discharged, right? It could be simple as just a regular virus to a pneumonia to a CMV reactivation or other infections. So infections is a common side effect with bispecifics. Low blood counts. That's late persistent is probably an issue more so with bispecifics. CAR-T. I haven't seen, and oftentimes when people have low blood counts, it's also if they have so much disease in the bone marrow, they might have low blood counts to begin with. So I think those are some of the side effects. With CAR-T, there's this question long-term whether there's a risk of getting other cancers and other malignancies. And I think it's too premature to have that data yet. We don't have that to comment on it, but that's a concern. And the delayed neurotoxicities is also a concern, along with low blood counts and what's called hypogammaglobulinemia. So those can be seen.
Right. Thank you. Okay, a couple questions here about T-cell exhaustion. If you could briefly explain what that is, and if there's a concern for T-cell exhaustion when using these different immunotherapies.
Well, yes, there is a big concern. That may be a reason why we think it's one of the concerns that the myeloma community has, whether, why does the CAR-T work so well in one patient versus another? It's just that, by this time your T cells are exhausted after you've had disease for so long. And that may be the reason why when you're doing the bispecific, the CAR Ts earlier, you should see better responses. And I think that same goes for even bispecifics. And it is a concern. So how do you develop CAR T cells where you select a healthy T cell population is actually a question. And also, what therapies precede your immunotherapy that, give you that sort of a phenotype? There are drugs that are out there that we end up giving as a part of bridging therapy or not bridging therapy that make it hard. So yeah, that's exactly a concern.
Yeah, our audience is very well educated. I'm proud of them. Okay, this is where it starts to get tricky because there's a lot of different questions, but they're all different. Let's talk about, do we have any data so far on genetics and how it relates to, does a certain genetic population benefit from these therapies more than others? For example, the translocation 1114 or 414.
I mean, I think, no, myeloma isn't, that's the one place we have to make a lot of progress, to be honest.
I agree.
We don't have we have personalized medicine, but not like that, it's not precision medicine to like that, where we can take your mutation, develop a target against it, and that's only unique to you or whatever. That's not what we have. No, I think what we know is that historically the high risk patient, the patients with the high risk, the standard risk patients usually do better in terms of how they respond to these therapies. Patients who have what's called extramedullary disease, they tend to do better. I don't think we have know that maybe the bispecific X, Y, and Z is good for T1114 or 414 or something like that. I don't think that. There is a trial. It's a phase 1 trial that's done with the by Multiple Myeloma Research Consortium. That's at first relapse, where they do explore several of these combinations of therapies. But that data is too premature and the trial's still ongoing. So we won't know if you take a drug that targets 414 or something called a BRAF mutation, are you going to see better responses or not? So I think that's ongoing.
Yeah, thank you. Okay, when a patient's trying to decide, or when their doctor is talking to them about that they're eligible for both CAR T and bispecifics, I mean, not that they could go wrong either way, but what are some advice, what pieces of advice that you give to patients when considering?
Well, I mean, I explained the process that, CAR T will require a waiting period, and your disease must be, it can be progressing, but not be something where you need treatment tomorrow. So that actually ends up dictating that. That CAR T requires a 7 to 14-day hospitalization in some centers. A few centers in the country are actually doing CAR T as an outpatient basis, because post CAR T, when you see CAR T, when you see CRS and ICANS is actually sort of very much dependent on the product that you get. With Abecma, it's early on. With Carvykti, it's a little bit later on. So, people are using that to sort of guide on how they can even do this on the outpatient setting. You will need a caregiver. It is sort of, the thought process is that the CAR T is one and done. But there is a lot of involvement or post CAR T, the first few months at least, routine, regular blood checks, regular visits, blood draws, maybe transfusions, low blood counts. So you must have the time and resources to be able to do that actually. But you get it, and then you deal with the aftermath of it. And then you go through a period where you're actually not on anything. So some people really like that phase, that finally I got a therapy where I can be off of a drug and I don't have to constantly every week go into a doctor's office. And other patients, while I think everybody wants a time treatment-free period, I don't think that's that's ever a question. But some patients may just not have the time or the resources to come in to devote that much time, and they don't want to come into the hospital. I mean, right now you have to come into the hospital even with bispecifics, but they just. I think everyone decides slightly different. I think anytime I've offered most people, CAR-Ts, usually the younger, the more aggressive the disease is, CAR-T gets prioritized. But also, when you get a slot where you are, that also dictates.
Mm-hmm.
So I don't think patients are at a point where they pick. I don't think we're there.
Mm.
Some may need it, but there's no slot and their disease needs it, the next week or whatever treatment, then they may not get it. So, it's a very individual decision. But I do guide, and I actually, with my patients, I always say, okay, this is pro and con of this is pro and con of this, but with your disease, I want to do this, but it's up to you. So I do offer my opinion because I think I am the most informed in terms of figuring out what that how to target that. But of course, my patient decides and makes a final decision.
Yeah, that's a great approach. Thank you. Thanks for being a great doctor. Let's finish with the conversation about sequencing, since I know that's a commonly asked question. The question here that we'll start with is, we're seeing some success in elranatamab and in teclistamab, which also target BCMA after a CAR-T therapy. So as a summary, a patient receives CAR-T therapy, which is BCMA-directed therapy. Then they can receive elranatamab or teclistamab and have some success. How is that possible? Is it just that the BCMA is it how does that work?
Yes, I think now with teclistamab's arrival, that's not going to be a challenge for the myeloma community. However, it was a challenge that we struggled for 2.5 years, when we only had BCMA targets approved or not, whether we have belantamab before, which was an antibody drug conjugate, and then CAR-T. So what we have known, and this is from real world, is that people who've gotten, and even from clinical trials, the people who've had a prior BCMA targeted therapy, the response to the second BCMA directed therapy is not the same as someone who's BCMA naive. That part is clear. The question is, how do you sequence? Do you give a bispecific first and then give CAR-T? Or do you give CAR-T and then give bispecific? I think what we know is that you get better responses when you can give BCMA bispecifics post CAR-T. And it may be that you have these CAR-T cells, they did what they could, and they targeted, and maybe now they've sort of depleted down or something. So you still have the target, and you can go back and hit it again with the bispecific. Whereas someone who's repeatedly getting bispecific on a weekly basis, and then they progress on it, and do it post CAR-T, we don't see the same responses. So there is an art to doing this, but I'm so glad that I don't have to be making that decision, because we got Telvay or teclistamab approved. Because I think now if somebody progresses on a BCMA target, they're unless it was like a really, really long lasting response and into years where they might feel, about challenging with the same target again, I think we'll go with something different. And that is something. And if that different target doesn't work, then we may try a BCMA again, right? So you want to give a time where there's a break from the same insult. So that's how I sort of see it. But honestly, there isn't a textbook that guides me to make these decisions. This is clinical experience and real world analysis and what we learn within the myeloma community, to be honest. But a lot of these questions are being answered with gold standard is always clinical trials. That helps us answer these questions.
Yeah, definitely. And thank you to all. I know there's some people on here that are either in clinical trials or have participated in clinical trials that make these approvals happen. So thank you to you as our audience who are willing to participate in those. And Dr. Kaur, I'll just give you the closing time to just either say thank you, you're welcome to just, you're like, I'm ready to go. Or or you can just give us any closing remarks about why you're excited about these therapies.
Sure. I have to go see 10 patients on the wards. No, first of all, I would like to thank everyone for showing up and listening to me talk. And I can certainly see that everyone who was here was very engaged, and that you could tell with the amazing questions everybody asked. I think as a myeloma physician, I am very excited about the options we have, and the remarkable progress we have made. And I think we will continue to make progress. And our next frontier in myeloma is that we've got excellent therapies, but how do we minimize toxicity from these therapies, whether it's financial, whether it's physical, emotional, and all that. So I think we are at that frontier in myeloma. We weren't there some time ago, but we got some excellent therapies. And now, how do we minimize the neuropathy? How do we minimize the DEX withdrawal? And how do we develop those kind of strategies so our patients can have good quality of life?
Very well said. Thank you so much. And thank you for all your hard work. I hope you get some rest tonight after your big day's over. So thank you so much for joining us.
Thank you, everyone. Thank you for your time. I appreciate it.
To my audience, I'll just keep you for a little bit longer as we do some outro announcements, and then you're welcome to go. I do apologize as I was not able to get all of your excellent questions. There were so many of them, which I'm happy about. I'm not complaining, but I always do feel bad when we don't get to all of them. Thank you for creating this discussion. It was amazing, and I couldn't have done it without your help. Some other events that we have upcoming on the 22nd at 6:30 p.m. Eastern is our Florida Myeloma Community Chapter. Everybody from no matter where you're from is invited to join us in this. We're going to be talking about gaps in myeloma. We did send out a survey saying, what gaps do you have in your myeloma education? And there were so many questions that were submitted, which again, I'm grateful for. We're going to be directing you in how you can find the answers to these questions and providing you with the resource sheet that provides a lot of answers to the questions that were asked. And then on Thursday, August 24th, we're having a conversation in our Black Myeloma Health Community Chapter about overcoming challenges, obstacles, and surprises together. The link to sign up for those events and even more events I haven't mentioned is found at the bottom of our slide. Another thank you to Amgen, AbbVie, Adaptive Biotechnologies, Janssen Oncology, Genentech, and Bristol Myers Squibb. And again, just thank you to each of you for helping make this discussion so amazing. And I'm really grateful for each of you. Hope you have a great rest of your day. Thank you. Take care, everyone.